Hi, this is Adam Glassifer from Info 732 with presentation of articles for Week 5 Design and Analysis of Evaluation Studies. Our first article, Automated Clinical Reminders for Primary Care Providers in the Care of Chronic Kidney Disease, a Small Cluster Randomized Controlled Trial. The purpose of this trial was to improve primary care treatment of chronic kidney disease. This addresses the problem that many patients with chronic kidney disease are managed by their primary care doctor and not necessarily a nephrologist, which at times can provide the patient with suboptimal care depending on the management guidelines being followed by the primary physician and the level of expertise and experience of the primary physician. This study was a cluster randomized controlled trial directed at 30 primary care physicians in a university-based outpatient setting, which followed their 248 patients with moderate to advanced chronic kidney disease who had not been referred to a nephrologist. Both groups received initial chronic kidney disease education, and then the intervention arm, which made up of 15 primary care physicians, received real-time clinical decision support for patients with a GFR of less than 45. This intervention recommended nephrology referral and a urine albumin if it hadn't been done in a year prior. The primary outcome of this study was nephrology referral along with some secondary clinical outcomes. The study ultimately showed no significant difference in groups with regard to referrals, proteinuria assessments, or other clinical outcomes. In conclusion, primary care physicians were interested in supplemental chronic kidney disease education. However, further study is required to determine the best deployment of CDSS to improve referral rates and clinical outcomes. Some critiques and takeaway points of this study were: it's a small single-center study. The CDSS used was a passive system which required physicians to then place orders instead of automation to the ordering system. It didn't account for primary care physician comfort or experience in treating chronic kidney disease. This could have led to some significant variations between the intervention arm. Also, the authors note that prior implementation of an eGFR reporting system had previously increased rates of nephrology referrals. This may have affected the lack of increase from this intervention. I think a good takeaway point from this article is that CDSS does not guarantee improved outcomes. Efforts need to be made to seamlessly connect CDSS with clinical workflows. Our next article is the impact of electronic reminders on venous thromboprophylaxis after admissions and transfers. The purpose of this study was to analyze the effect of electronic reminders on thromboprophylaxis rates for admissions and transfers within the hospital. VTE prophylaxis is an important part of patient safety and outcomes for hospitalized patients. This can often get lost in patient handoff during admission and transfers and poses a potential risk for the prophylaxis to be missed. CDSS has the potential to close this gap. This was a prospective study which looked at 2 study periods in 6 departments of a university hospital. 3 of these departments received additional VTE reminders 6 hours after admission or transfer if the VTE prophylaxis had not been previously ordered within 30 hours of arrival. The study found that VTE reminders had a significant effect on prophylaxis rates in admission and transfer of the intervention group. No significant change was noted in improved clinical outcomes of the intervention group. In conclusion, VTE reminders improved awareness of VTE prophylaxis orders on admission and transfer within the hospital. Some critiques and a takeaway point of this article are that a larger sample size would be needed to determine the significance of clinical outcomes. Also, different departments have varying knowledge and expertise in the use of VTE prophylaxis orders. This may have limited the study depending on where the admission was made to where the transfers occurred. It also did not specifically note which study departments were in the intervention arm. This may have also affected the results. Lastly, the algorithm that checked for prophylaxis orders cut down on the number of reminders. This is actually more of a positive and leads to the takeaway point in that the more directed that CDSS can be, the more likely it will be effective and not just additional noise to the clinicians that will be using it. Our last article is the implementation and evaluation of an integrated computerized asthma management system in a pediatric emergency department, a randomized clinical trial. I will say this is a study that I'm previously well aware of, as we recently implemented some standardized asthma therapies within the pediatric emergency department I work in. The purpose of this study was to determine whether patient eligibility identification by probabilistic disease detection system combined with an asthma management system embedded in the workflow would decrease the time to disposition. The problem they sought to solve here were that standardized care and early initiation of asthma care in the busy ER setting has been shown to improve outcomes. However, integrating into the workflow can prove difficult. This was a prospective randomized controlled trial in an urban tertiary care pediatric ED. Patients identified with asthma randomized to either the intervention or control group. The control group received standard-based care on guidelines, while the intervention group had integrated computer-driven asthma management system tied to CPOE order sets based on these guidelines. Clinicians then received follow-up study after the study completion, which assessed the overall implementation. Primary outcome was time from triage to disposition. Secondary outcomes were asthma guideline adherence measures. The results of this study showed that median time to disposition, hospital admission rate, and ED length of stay did not differ between groups. So this essentially means that computerized management system did not add additional time to disposition, but it also didn't necessarily speed up the time to disposition. Although no effect was seen in the disposition time, it did improve communication among the multidisciplinary care team. Also, no measurable impact on outcome measures were seen. So, some critiques of this study is that the primary outcome measure is flawed, as patients could potentially spend varying amounts of time between triage and initiation of treatments depending on ER volume or other variable things happening in the ER at any given time. Also, clinicians were not truly blinded to the study, since the use of the tracking board employed some measures that indicated that a patient would be in the intervention group. Also, this was a single center study. I think the biggest takeaway point from a study like this is that automation and integration of care may not necessarily lead to tangible results. However, improved communication among a care team benefits everyone, provided that the implementation does not slow or halt the workflow. Some similarities among these articles are that the implementation of CDSS does not guarantee improved results. Also, CDSS must be carefully and thoughtfully integrated into workflows in order for it to be truly effective. And I think the biggest takeaway point from these articles are that the design of an evaluation can have an effect on the analysis, and of course on the results as well. Some differences of these articles are that they really show that different study designs can yield different limitations that need to be overcome. And then a very interesting point, which was seen in the asthma study, is that qualitative study elements can help to provide meaningful results even when the data may not necessarily support the primary or secondary outcomes. So with this, they did a study at the end that did a qualitative review of the intervention, and ultimately this showed some meaningful results in that the communication among the care team was improved. In discussion for this week, I have two questions. Do you feel that CDSS helped to improve patient care or simply create more noise for clinicians to filter through? And lastly, how can the analysis of an evaluation overcome design flaws? Here are the listed references. Thanks for your time, and I look forward to your comments.